last week we had a great discussion around very specific protocols and frameworks that are being used in the ICU, both in London and in New York City. One of the conversation topics that was proposed for this week was to move that focus into the emergency room, given that it's a point of intake, not only obviously around for COVID operations, but also the standard ER patients that may be coming in. Some of our partner institutions have seen a decline in certain types of patients and wondering what's causing that, and just wanted to get a sense of what people on the front lines of the emergency room are seeing. So to introduce our guest speakers, I'm going to turn over to Dr. Preston Klein. So Preston is one of the co-founders of the Mission Critical Teams Institute. And that website, for those who are interested, is missioncti.com. But their work is focused on mission critical teams of 4 to 12 people who do high stakes, high pressure, life and death work. So at Arena Labs, they've been a phenomenal partner in thinking rigorously. They do a lot of academic research, and they work with a number of teams, not just in medicine, but in special operations, things like people in FBI hostage rescue. And they've got a deep expertise in much of what you all are living right now, which is teams that are having to be brought to life in a crisis environment. So very much appreciate Preston stepping in to mix up our voices here and moderate a discussion between two of his good friends. So Preston, let me turn it over to you.
Brian, thanks very much. I'm really honored to be here and really impressed with what your team is doing. I want to quickly just introduce our two panelists. I'm going to start with L.A. Alvarez. I'm just going to read a little bit because he's the clinical assistant professor of emergency medicine at the assistant residency program director at the Stanford Emergency Medicine Residency Program. He's also the co-chair of WellMD's Physician Wellness Forum and spends a significant amount of his time thinking about the morale and resilience of medical workers. Thanks for joining us, LA.
Thanks a lot, Preston, and thanks for having me here.
Glad to have you. And then next I'm going to introduce Dr. Colin Bucks, who used to work with LA at Stanford, and I've known for a while, and is now Senior Associate Consultant in Emergency Medicine at the Mayo Clinic. It is relevant to note that Colin also responded to the 2014 Ebola outbreak in Liberia. Colin, thanks very much for joining us.
My pleasure. Thanks.
I think what we'll start with is just a sit rep from both your perspectives. I know that you both have a lot of experience in emergency medicine. You're both at premier institutions. And so just starting with you, Colin, excuse me, I'll probably do that more than once. Starting with you, Colin, why don't we just spend about 2 minutes on just giving us a sit rep?
Yeah, so I am helping staff our hospital incident command system and then also still clinically working. What we're seeing the most of right now is dramatic declines in patient volumes. And what I think we'll want to study as excess death related to people being fearful now of coming to the hospital. We are seeing COVID-19 patients, but it's Minnesota, so not nearly the volumes that the coasts have seen. But certainly they're in our both dedicated ward and in the ICU. We've put a ton of work into, and I'm going to want to share some stuff about our approach to PPE, not the techniques, but the education on PPE that have been essential. But we've also spent a ton of time implementing our telehealth, both to see patients remotely, but to use telehealth in the emergency department to limit the physical contact. So we've got 30 tablets encrypted that I can go and see a patient or provide updates just by looking at my phone and talking to them face to face. And we're seeing this dramatic increase in telemedicine just being accelerated by this outbreak. And I think it's going to be here to stay after we achieve our new normal. That was a very quick blurb, but happy to expand on some of those things.
Thank you very much. LA, over to you.
Yeah, similar to Colin's experience, our volume, and Matt Sitter actually showed this graph as well with a declining number of cases in California. Over the past couple of weeks, our volume has significantly dropped. So estimates being like we're probably about half the volume that we're seeing, which is a little bit eerie in a sense that, so we normally expect patients that come in, at least like about 20% of our patients, for instance, will come in with chest pains. Like we don't really see that as often anymore. And for fear of contracting coronavirus while they're in the emergency department or en route to the emergency department. And so to that point, we've significantly changed our staffing model to reflect that. One idea was initially at the very beginning of this a month ago, there was a lot of confusion of what kind of PPE to use, and how do we deploy staff, what happens if they get sick. And so like, as we were learning about our patient patterns, we, as a residency program, for instance, decided to decrease the exposure of our residents in emergency medicine in training. As a way of background, our residents go to 3 different sites, which means that they have 3 different big institutions kind of telling them the PPEs and what to do. And similar to Colin, what we've done is we're about to actually publish this. We developed a mastery learning module for donning and doffing because what we're realizing is even the video things that we're watching that's required is not enough during the heat of the moment when you're about to go into each of those hot zones.
Colin, is there anything you want to add to that?
Yeah, in terms of, this is something that we saw, that I read tons about in SARS, what I experienced in Ebola, and then when this started out, I knew that this was going to, angst and insecurity about PPE will always be present. And we had to take this on directly. And so there has to be a common source of truth, and there has to be consistent messaging, because PPE does change. And PPE will change due to scale, scope, and duration, not because we've learned something dramatically different about the virus, but each time you change it, the staff goes through a ton of anxiety. Why now? Am I still safe? Was I not safe before? So our leadership in our department, nursing and physician, rounds 3 times a day to review the most recent guidance. And this was what was necessary to get our staff comfortable and answer their questions, also solicit their feedback. It'd often be just like the phlebotomist would say, yeah, but what about this? And we'd have to go back to the infection prevention and control group and say, hey, how are we incorporating this? But it was that consistent messaging and saying, this is going to change. So, and also we send out a newsletter every day, and they all get archived on the same website so that people know, if I have a question, I go here. And these people will be rounding at the beginning or end of my shift, and I can ask these questions. But it took this concerted effort, and now our department is wired. It's like the most adherent and the most comfortable, and people will tell you, yep, it's going to change in 4 days. We know why. And they're so much better off than where we were 4 weeks ago with that. And so that's something that, whether or not you're using electronic forms or physically going around, going to the place to talk, any department can implement that, and will bring tremendous reassurance to your staff. With that said, you have to know the why. Yep. You can't just go in and say, we're changing now, because your staff won't trust that. You have to say, we're changing now because, sorry.
To both of you, no, it's all good. Thank you very much for both of you for that. I guess from my perspective, right, listening to you both talk and being on these calls previously, when you think about the Delta, the things that have been changing in the hospital over the last few weeks, how much of it is it about tactics? How much of it is no kidding, just straight up medicine? And how much of it is anxiety, psychology, emotional approach, effect of uncertainty upon people's day-to-day sort of mindset?
So I'm grateful to be in a place where we have enough staffing and expertise to actually focus. So my main focus is on that morale aspect. And there's also like teams that handle just the operations aspect of this. So I can cognitively offload that and just really focus on the morale. So I think to answer your question, at the very beginning, there's a lot of confusion, especially since we're getting, at Stanford, we're getting so many information from so many areas, even within the hospital. And also the way that we practice somewhat changes, because our critical care zone will have an ante-room, for instance, like simple logistics like that we'd never really considered before. That's, you have a separate room to clean and wash your hands, as opposed to the majority of the rooms in the hospital and the rest of the country, you don't really have that. And so the way that you would take off your gowns and whatnot, or putting in your gowns and where you're going to do that, affects how you're going to potentially spread the disease. And that created a lot of angst. There's also, on an initial surge, people were nervous or worried with the level of infectivity. And similar to what Mayo has done, we've had just digital evaluations of patients using iPads, which really significantly minimized how we would go in, because we had to, from a morale perspective, we have to address who goes in first. Does the nurse go in? Does my resident go in? Does the attending physician go in? words like human shield were being used, and not just at our shop, but like pretty much like across the country. I train in New York, so I would hear it from my colleagues in New York City. And so things like that we had to address, and using telemedicine was a great way to really minimize exposure for everybody, and create this a team approach of taking care of the patient.
Thank you. Colin?
The dichotomy of operations versus psychology is an interesting one, but we did have to change the format and size of teams engaging with any patient, and that changes your communication. You know, there were some tech answers to that, but I don't really believe in tech with communication. I do, but I don't. I want systems to work reliably. And when you get down to sleeker teams, it is easier to have the inter-team dialogues going on. And separating people from, only a handful of people go into this room to pursue a resuscitation that used to, at a large institution, could have 8 or 12 people in a large resuscitation bay. And now we say, nope, 3, 4 at the max, and everybody else is out, and there's only one line of communication in, back and forth. That's, yeah, the etiquette of the structure of the resuscitations has changed and been refined pretty quickly, all in the name of reducing the chain of transmission.
So we're about to turn this back over to Brian and see if there's any questions from the audience. But before we do, are there any sort of big takeaways that either one of you would want to share with the docs on this call, or the medical folks on this call, excuse me?
I think it's important to make sure that the questions like Colin was mentioning is addressed from each staff, including even if it's like from an intern level, from a medical student perspective, and really just sit down with them and answering all of those. So creating multiple venues asynchronously or even outside of the clinical practice is very helpful to help minimize a lot of these confusion, anxiety, and even fear for going into the front lines without added PPE based on what they've heard from multiple places. It's also very important to streamline that. So you have to own your department, because ICU will have their suggestions, the School of Medicine will have their suggestions, CDC will have their own unique perspective, and really the emergency department has to just synthesize all of this and then create this platform. So one of the key things that we did immediately when people were getting confused was every day the clinical operations people and the residency program leadership would meet at 4 p.m. for an hour to just hash out any of these questions, to give voice to our residents, because from their perspective, there's power dynamics that they may not feel us listened to.
Yeah. Colin, thank you, LA.
The takeaways, I gave a talk to the U.S. Forest Service about a month ago, and the title of the talk was "Comfortable Being Uncomfortable." Things are going to change, and it's okay to feel that anxiety. As leaders within our groups, we have to address the why and acknowledge that we're asking everybody to be comfortable being uncomfortable. I love all the stuff that Alay said. I love watching our teams get a little sleeker, and I love people actually thinking critically, not just about what is this mask, but what is the actual mode of transmission of the illness. And that is, to me, how they become empowered.
Thank you both. And I just would say in my conversations with both of you independently, one thing I would encourage everybody to think about is that we do not want to create this amazing situation where we survive COVID only to lay the seeds of future suicides, right? And so what we need to be doing is just making sure, giving ourselves permission to solve not just the problem in front of us, but the problem down the road. This mental health is not a new issue for medicine, but it's certainly more acute now. And I think we have to go out of our ways to make sure we're looking after that. Thank you both. And with this, I'll turn it over to Brian and with any questions or comments.
Yeah, Colin, LA, thank you both very much. And Preston, hey, before we go to broader questions, I'm curious, Preston, I mean, given the work you've been doing for the last 10 years with mission critical teams, what you've seen in this environment, anything that's been coming to mind for you lately in terms of, back to our conversation around people who are operators in this case on the front lines, are hungry for tactics or models, frameworks that they can apply. What's been on your mind as you've been watching things develop nationally and internationally?
Very briefly, Brian, when you and I first met, one of the first conversations that we had was the change in special operations around 2003 and 4 after people first went to war. they were trained in the 90s during a time where there wasn't war, and all of a sudden a bunch of traditional practices weren't working. I think in medicine, we're there right now. There's a bunch of people that are entering this world with a bunch of assumptions. Well, this is going to work. And we're encountering a fundamentally new problem, and we're going to have to approach it new ways. And some things that we've been taking for granted for a long time around communication, about connection and belonging, and a whole bunch of other just human things, we can't anymore. We're going to have to readdress them and address them in new ways. And LA is actually one of the broadest proponents in the US of this stuff. And so I sort of follow your lead on this, LA.
We're always deeply humbled here for you making time. Super grateful to be involved on the margins, and for those on the front lines, appreciate what you continue to do and the way you're learning. But today for LA and Colin and Preston, thank you again.